Bismillah ar-Rahman ar-Rahim. Let us start the last and third part of weaning. There are a lot of factors should be considered when you take the decision of weaning. The first one, which is the patient should, this weaning should be in the morning. You should not allow it to be evening or at night. Because the team should be, all the team should be available and should be alert. At the same time, the patient should be awake and of sedations. Sometimes can't word, this is relative. Sometimes no need for the patient to be awake. Sometimes the patient, you with the patient with a trauma or mechanical ventilations for some other reasons. And after that, the patient's ventilator problem, the ventilator status of the patient became normal, and still the patient in coma. So the patient can be intubated, but weaned off the ventilator. Be aware that of depression and psychological limitation of weaning in the patient, conscious patient. Proper positioning is very important to guard against aspirations, adequate nutrition during the weaning stage, because of the problem of muscle wasting and cachexia, and which will affect the respiratory pump. Optimum fluid state, not to be dehydrated or not overhydrated, because this will interfere with the liberation of the patients. Also, the patient should be infection free, otherwise this will have a high metabolic state. Hemodynamically stable, so the patient should be off vasopressors. Sometimes you put the patients on with heart failure or pulmonary edema on the mechanical ventilations, and you leave the patients on both venotropics, and you can wean him the patient from mechanical ventilation. This is another issue. No angina pain and no active bleeding should be considered. Metabolic state should be corrected. The electrolyte all should be corrected. The patient should be febrile, normal sleep and wake cycling, no bronchospasm or minimal bronchospasm, intact cough. If there is not intact cough, you can wean the patient of the ventilator, but leave the endotracheal tube or tracheostomy tube. Normal thyroid functions, I think, if the patient is suffering from thyroid problem. Then come the questions how to wean. This is very important. How to wean the patient of the ventilator. I think there are two methods of to wean the patient, to liberate the patient from the either abruptly or gradual. Abrupt, this means that it is usually done for cases of acute reversible respiratory failure, where the cause of failure is cured and the respiratory reserve capacity is nearly restored, and in this case no need to keep the patient on the ventilator. Sometimes you are faced with the patients who took some sort of the narcotics or morphine, this is like addict, and just put the patient on ventilator for a short time and give him the antidote, or after reversal of the effect of this drug, the patient starts to take his breath, you can wean him and disconnect him immediately, no problem whatsoever. So this is an abrupt one. Or a spontaneous breathing trial. This is before you disconnect the patient. Sometimes you want to be sure that the patient is taking his breath normally. This is what called a spontaneous breathing trial. This is just disconnect the patient and leave him on the TPs. Sometimes you put him on CPAP. I'm going to discuss what is different between CPAP alone and disconnect the patient from CPAP and keep the patients on the endotracheal tube or TPs. I think this is another load, but this should take care of it from the CPAP, and the patient is going to take his respiration well. So you can disconnect the patients and extubate the patient immediately, or leave the patients on the TPs and see whether the patient is going to take his breath normally for half an hour or 2 hours, and after that disconnect the patient. And spontaneous breathing test as a weaning method. This is this increasing the length of spontaneous breathing. Some sort of training the patients and be sure that the patient can be liberated from the ventilator without recurrence and reintubation. So, abrupt weaning, as I've mentioned, this is the patient, put the patient on CPAP, and after that, CPAP 5 or 7, and for 1 and 2 hours with the normal tidal volume, normal respiratory rate, and cardiovascular system, normal pulse rate, normal blood pressures, and everything is normal. I think this is you can disconnect the patient even with FiO2 less than 40%. Abrupt weaning, this is after 5 minutes. I think this is a problem. I am going to discuss to explain it. Gradual meaning sometimes some patients, sick patients who suffered either chronic respiratory failure or remained on the mechanical ventilation for longer time due to any cause. So the problem is that these patients suffer non-reserve capacity or endurance closer to the threshold failure. That's why weaning policy is meant to train the respiratory muscles to increase its power, endurance, and reserve capacity to sustain respiration for infinity. We have got several methods for gradual weaning. Number one, this is once daily for the spontaneous breathing test. This can be you can test put the patient for disconnect the patient from the ventilation and put him for spontaneous breathing on the T tube and see for half an hour or something like that. This is once per day and see the patient how much the patient will stay without failure. Multiple tries, this can be done per day. Just put the patient on the TPs. If the patient is fulfilling all the criteria, put him on the TPs several times per day in order to see whether the patient is going to sustain for a longer time. If the patient stayed for 2 to 3 hours without any problem, this in this case you can wean the patient. What are the modes of ventilator? Sometimes you put the patient off SIMV. This is SIMV, it has a mandatory, it has and spontaneous. And this is SIMV, put the mandatory, and after that decrease the mandatory till you shift from the mandatory, from the SIMV to the pressure support. And from pressure support to CPAP, and from CPAP disconnect the patient. Also the same thing, this is a pressure support. Pressure support decrease gradually till you go to CPAP, and from CPAP disconnect the patient. This is that's it. When you look at this, this is SIMV. This is SIMV. This is the respiratory rate. The mandatory is 12, and this is the pressure support is added. So see the patient from 12 to 10 to 8, and after that, if the patient is shifted to CPAP and see the respiratory rate is within the normal, the tidal volume is the normal, carbon dioxide is normal, oxygen is normal, low FiO2, and all these data, so we can disconnect the patient. This is the SIMV. This is the mandatory, and this is the spontaneous. Decrease the number of mandatory and shift from SIMV to the pressure support. This is the pressure support. This is they have the beep, and this is the pressure support. Decrease the pressure support gradually till you get to the CPAP. This is the CPAP. This is the final stage for all of them to go to CPAP. Because CPAP, I'm going to explain. CPAP, this is spontaneous, and all the workload is done by the patient. And you'll see. By BAP, also the same. We have high level and low level. Decrease gradually the high level and leave the patient with CPAP. That's it. This is the high, and this is the B. This is the beep. In this case, it will be the lower CPAP, and this is higher CPAP. This will come down with it till it is with this high one till it is 0, and in this case you will convert the patient from high from BiPAP into CPAP. uh, uh, Considering the respiratory pump and the cardiac output during weaning ventilations with pressure support ventilation, I think this is what we call this is the cardio-respiratory interactions. There is an interaction between the two. When we wean the patient, we should not stress look only at the respiratory functions, which is the tidal volume and respiratory rate. We have to take care that it has an impact on the cardiovascular system. So take care of the heart rate and at the same time the cardiac output or the blood pressure. Considering this respiratory pump, when you look at the respiratory pump, this is the pressure support. When you wean the patients, you shift from SIMV or by BAP or whatever, this is to the pressure support. This is the pressure support. In this case, look at this. This is the driving pressure of the ventilator, and this is partial. This is aided by the driving pressure of the patient in order to satisfy his demand. And when you decrease the driving pressure from pressure support 20 to pressure support 10, this means that the patient is going, the patient is good. This is the patient will increase his driving pressure to keep the tidal volume normal. When you decrease more, the patient will increase to keep his tidal volume normal. This is a problem. When you go with the pressure support 0, and the tidal volume is the same, and the respiratory rate is the same, this means that the driving pressure exerted by the patient is sufficient to take this his breath and take this tidal volume. So this means that this patient is good. I decrease the ventilatory support, and the patient is compensating. Decrease the patient compensating. Decrease the patient compensating. No support by the ventilator, no driving pressure, no support by the ventilator. The patient, this is the only driving pressure. This is the only work done by the patient. So with the same tidal volume respiratory rate, this means that this respiratory pump is the patient is good, and I can wean the patient from the ventilator. That's it. This is a decrease, and this is increase. Decrease from the ventilator and increase in the patient. This is a work done by the patient only, without a change in the respiratory rate or the tidal volume. This is good, so I can ventilate the patient. Same thing. This is a work done only by the patient, and no tachypnea. No, the tidal volume is good. Minute volume is good, and the carbon dioxide is good. At the same time, the oxygen low FiO2. This means that you can wean the patient out the ventilator. What about the interaction with the cardiac? Very important point. You have to look at this is when you look at the ventilator, we say that the ventilator is making some, so what we call unloading the left ventricle. He makes unloading to the heart. Unloading to the heart. This means that he's decreasing the afterload. How does it come? This is the formula. Left ventricular workload is equal to the diameters of the left ventricles multiplied by the left ventricular transmural pressure. Left ventricular transmural pressure. This transmural pressure is the result of two things. This is the pressure resistance in front of the left ventricle, and the pressure. This is the what we call the pressure in the cardiac fossa, or the pleural pressure. Over the this is the diameter, means half the diameter for 2, and the wall thickness. So this is the left ventricular transmural pressures, and this is on spontaneous breathing. The left ventricular free wall is doing an effort against the resistance, and against also the negative pleural pressure. So when you take your pressure, when you take your breath, you make a negative pleural pressure -5 to -10. This -5 or -10, this is the dragging pressures of a left ventricular wall, and at the same time, this left ventricular wall is trying to push here. So this mean arterial pressure, so the resistance here will be added to this one. So this is if it is 5, and if this mean arterial pressure is 100, and this 5, so the work of the left ventricle will be against 100 plus 5, means 100.5. This is normal. If the patient is having, say, the patient is having pneumonia or ARDS, this means the patient, in order to allow the delivery of the tidal volume 500, he has to make to exert a high negative pressure. Instead of being 5, might go up to 30. So this means the negative pressures, or the pleural pressures, which will be transmitted to the cardiac fossa, will be -30. -30 plus 100, so the afterload in this case will be 130. This 100 is too much. This case, that's why when you put the patient on the ventilator, you put the patient on the positive pressure ventilations, and instead of this negative, it becomes positive. Positive 30 or positive 25. So you are pushing with the ventilator, with the heart. You are pushing the heart by this positive pressure. So the transmural pressures will be 100 minus 30 will be 70. And instead of being 130 in this case for ARDS, here in this case, after putting the patient on the ventilator, the transmural pressure dropped from 130 in this case to 70. 100 minus 30. This is our pushing. That's why this is an unloading problem. This should be considered while you are dealing with the patient. Look at this. This is another simulations. When you look at this, this is the negative pressure. This is the cardiac fossa. Taking deep inspirations, this means that there's a negative pressure which pulls the ventricles outside, which pulls outside. So this is the ventricle is trying to push out inside, and this is pulling outside, so against it. So this is this is a normal inspiration. This is a normal, and this is a point should be considered when the patient is breathing normal. And look at this. This is a patient with pressure support 20. Pressure support 20 here. The patient is making some sort of effort, but the major driving pressure is that of the ventilator. So it is a pushing pressure, it is helping the patient, it is unloading the heart, it is unloading the heart. When you decrease this, this means that you are decreasing the positive pressure. Instead of being of 20, now it is 10. 10, say the patient is making another 10, so the pressure, or 5, so the driving pressure, or the helping pressure, which is a positive pressure for the to unload the left ventricle, becomes low. When you come to CPAP, there is no positive pressure. All of it is negative now. It is negative pressure. So the unloading of the left ventricle with pressure support, now there is no unloading, and on the contrary, there is a reloading of the left ventricle during CPAP. So if you put the patient on CPAP and the same blood pressure, no change in the blood pressure and no change in the pulse rate, this means that the reserve capacity of the heart is large, and so this means that you can wean the patient. So by this way, look at this. This is the problem. This is if this is a patient with a normal patient. This is the patient is normal and he's taking a pleural pressure, thoracic cage. This is the pump with negative pressures about 7. This negative pressure will be transmitted to the alveoli by about 1 minus 1. This allows the flow by this 0.5 liter per second to give us this tidal volume. Look at this. But if here, look, if the patient have some sort of troubles, and the patient, in this case, they have some sort of pneumonia, or there's something like that, or you put the patient on the ventilator on endotracheal tube. I mean here, this is the patient if the patient is having endotracheal tube, and you disconnected the patient of the ventilator with the TPs. TPs, this man means that there is some sort of increased resistance. So the patient should make a larger pleural pressure in order to reach to the same alveolar pressure, to have the same flow, to have the same tidal volume. This means that if the patient was on CPAP, the value of CPAP was a 5, 7, something like that. This is to overcome the tube resistance. If the patient was good on CPAP and the data are okay within the normal range, so you can disconnect the patient and extubate the patient. If you leave the tube for some time, this means that you are adding some resistance to the patient. So this will appear in the form of this negative pressure in order to deliver the same tidal volume. If there is some sort of reserve to the patient, in this case, the reserve, this means that if the good reserve with the patient, and the patient is having the same tidal volume with the same rate, this means that the reserve capacity of this patient is good, and we will be sure that if you extubate the patients, this means that the patient will tolerate and will continue. What are the criteria of success or failure of weaning? I think this is the last things. Criteria for success: no diaphoresis. Yeah, the patient is at normal tidal volume, normal respiratory rate, normal heart rate, normal blood pressure, no cyanosis, no so. Even if there is some sort of stridor, you take care. If the patient develops stridor, this might lead to increase in the load on the heart, and this is the patient might develop pulmonary edema. The only solution for this is to put a tube only, just to put a tube in order to avoid the heart failure. No chest pain, no, and this bilateral rate, as I've mentioned, this is a very important point. Criteria for success: all the criteria for failure is the reverse: decrease in tidal volume, increase in the heart rate, increase in respiratory rate, increase in heart rate, decrease in the pressures, and the criteria for impaired perfusion. This should be considered while you are dealing with your patient. How to extubate the patients? The extubation of the patient should be done in the morning, after fulfilling the criteria of weaning. Assure the patient, explain the procedure to the patient, suction airway as needed, place the patient in head elevated or semi-upright position, ask the patient to take a deep breath and hold it, deflate the tracheal cuff, and with the syringe and withdraw the endotracheal tube rapidly and smoothly while asking the patient to exhale. Encourage the patient to cough and put face mask with 40% of oxygen. And thank you.